Dr. Mehran, Pakistan is made up of 5 provinces. The second largest province is Sindh, but it's also called Mehran. So we have named the province after you. Welcome.
Thank you, Professor Faruqi. It's really an honor and a pleasure for me to represent the American College of Cardiology at this wonderful meeting, and I feel very honored to be included in this forum with all of the professors, my colleagues, my friends in Pakistan. As you know, I'm originally from Iran, your neighbor, and my father made a lot of trips to Pakistan during his service back in the 70s. And I remember many, many times when it was his favorite place to visit, where he received the best and the friendliest welcome from the Pakistani people. So it's wonderful to be here with you. Thank you for having me.
Dr. Mehran, welcome to your second home. And without further ado, let's hear you talk on the acute coronary syndrome.
So this evening for you and this morning, I thought we would talk about acute coronary syndromes and to give you an update on diagnosis and management. These are my disclosures for all of the clinical trials that I run at Mount Sinai. As you know, I have an academic research organization, and my center is responsible for multiple clinical trials in interventional cardiology and also general cardiology. I want to first start with the fourth universal definition of myocardial infarction, because there are important new concepts in the definition of myocardial infarction that we should really be understanding. And we're hearing a lot, especially now after the Excel and ischemia trial, a lot about myocardial infarction, peri-procedural, post-procedure, and presentation, and spontaneous myocardial infarction. And let me just make sure that there are new concepts now in the universal definition where there's a differentiation of myocardial infarction from myocardial injury, highlighting an important difference between myocardial injury after cardiac and non-cardiac procedures as discrete from myocardial infarction. So it's important to note that. So beginning with the diagnosis of a myocardial infarction, obviously these 4 pillars are always there for all of us in clinicians, but the ECG is incredibly important, and the guidelines talk about that in STEMI, the 12-lead ECG being one of the most important parts of recording and interpreting myocardial infarction. Maximum target delay of 10 minutes is what it's asked for as soon as possible. And then, of course, having defibrillator ability there for suspected myocardial infarction. And of course, we all know that this is where we are with the ST elevation, making an important decision whether there's non-ST elevation versus ST elevation myocardial infarction, because there are different treatment modalities for those. Because in non-STEMI, obviously, it's still class 1 indication to go forward with a quick emergency arrival and getting the patients into a 10 minutes of an ECG. And then the serial ECGs are 15 to 30 minutes. And the continuous monitoring is actually interesting. It's a 2B recommendation. Cardiac biomarkers are very important. Obviously, class 1 indication to rule in and to rule out. And the high sensitivity troponin assays is what's being measured mostly in the United States, and I think now around the globe. And then, of course, there is this rapid rule out, rule in protocol at 0 hours and 1 hour recommended if there's a high sensitivity troponin test validated. I think it's also important to have an important risk assessment. There was this Compass MI project risk assessment where they looked at patient level data in close to 23,000 patients, coming up with a risk assessment tool that actually integrates troponin on presentation, dynamic changes with serial sampling, and the time between and obtaining these samples. And of course, this rapid TNT study was very interesting with a randomized trial of 33,400 patients, standard care versus intervention, where this rapid triage strategy was very, very safe and was able to rule in and rule out patients without an important poor outcome on the patients who got ruled out. And then, of course, we saw at last year's ACC the presentation of this very important trial, the historic trial. It was a single troponin testing where there was a suspected acute coronary syndrome patients in over 31,000 patients. And this population had a rapid rule out versus a standard rule out pathway. And it was interesting, they weren't able to actually show that there was non-inferiority in terms of MI and cardiac death. They didn't meet that criteria, but the rate was numerically lower for those patients who had the rapid rule out. So once we figure out that we made the diagnosis and rule in myocardial infarction or an acute coronary syndrome, where are we with management? Well, PCI, I think there's no question that has been, after 16 years of having the NAMI study presented PCI versus fibrinolytic therapy showing that PCI is superior. And there's no question that fibrinolytic therapy is inferior in terms of obviously intracranial hemorrhage, stroke, and there are important contraindications, obviously, to fibrinolytic therapy. But most importantly, it has to do with the fact that PCI, when you have ability to get the patient to a PCI center, that is the way to go. And then, of course, fibrinolytic strategy comes into effect, and I'm going to let Dr. Wilson give you those data when he's presenting his late presenters. I'm not going to talk about that today. This is the DYNAMI 2 16-year follow-up showing the importance of and the superiority of primary PCI 16 years out compared to fibrinolysis. The benefit stays and is maintained over the full period of follow-up of these patients. So when you can, and if you can, please refer the patients for primary PCI. Very, very important. Then the other thing is this door to balloon time. We've done a very, very good job in reducing door to balloon time. And as we did, the door to balloon time reduced over the last couple of decades in over 100,000 patients. This was published in 2013. And it was really upsetting for me to see the flattening of the curve in terms of mortality. Mortality has not changed. Reduction in mortality has not changed, even though we've reduced the door to balloon time, which begs the question, we need to go outside of the hospital and get to the patients and get them quicker from the symptom of onset into the hospital. And then once they get in, we've already done a great job in reducing door to balloon time. And still, if you can see here, for the recommendations for optimal results is really for getting if there is fibrinolysis or whatever it is, you have to train and equip and identify STEMI. It's recommended get the patient to a PCI capable centers. And then of course, very important that there is a bypass of the emergency department. Get the patient straight up to either CCU or to the cath lab directly. And that's really been able to cut down times. What about where we are in terms of access? What do we do when we get the patient and immediately get them to the cath lab in acute coronary syndromes, radial versus femoral? And I think there was no question this was the MATRIX trial. Large numbers of patients. This was presented a couple of years ago. Radial access gives you a consistent benefit across the spectrum of patients with acute coronary syndromes in terms of reduction of all-cause mortality, MI, and stroke. And furthermore, a very important and most important reduction especially in the STEMI patients, in bleeding complications. And also, both in STEMI and non-STEMI, there was a big, big reduction in bleeding complications, and you can see the reduction of all-cause mortality, MI, and stroke, very prevalent in STEMI patients when possible. What about in non-STEMI? What's the optimal timing? Well, the TIMAX study has shown in a large numbers of patients, over 3,000 patients, let's go to quickly over 24 hours versus just a little bit delayed above 36 hours in non-STEMI. I think we know STEMI right away, get them to the cath lab. What about non-STEMI? Can we wait a little bit? It all depends on the risk of the patient. If you have a high risk patient, the overall risk of a patient, the underlying risk is what is extremely important. And what it means is that if you have a high-risk patient, an early intervention is very, very impressively important. The low to intermediate risk patients, you can wait a little bit, you can go up to 36 hours. But when you have high-risk features, dynamic STT wave changes, symptoms that are not being relieved, and hemodynamic changes, you gotta go quickly to the cath lab and reperfuse that patient. What about the non-infarct related artery? As you know, this is a very, very important issue that has been brought up. Used to be harm in the past in 2013. We were very, very adamant that PCI should not be performed in a non-infarct related artery. We came up to a 2B in the focus session of in 2015. And really, this was a modified recommendation to a 2B because of these trials, Anami 3, Primulti, and Culprit. And important to note that the European guidelines gave it a 2A. After all of these data, they upgraded it from their previous study because of these randomized trials. And you know that these randomized trials showed that there was a reduction. They were all small, but there was a reduction in ischemic endpoint of the patients who had complete revascularization, and they had multi-vessel primary PCI, and this was in hemodynamically stable patients. The PRAMI study is one of the first studies that actually looked at this. This was a study of patients with STEMI undergoing infarct-related artery PCI, and they did go to the limited to the infarct artery, or what they call preventive angioplasty, in angioplastying the non-infarct related arteries in the same setting, and they showed a very big reduction in their in the composite endpoint of the primary endpoint of cardiovascular death, MI, and refractory angina. And then this was really, we always said that was an underpowered study, but really this, the biggest study, the most important study that I believe wholeheartedly will change the guidelines, most likely to class 1. We don't know that, but it should happen, because this is over 4,000 patients. We just presented this at the European Society of Cardiology. STEMI patients, 4,000 patients evaluated at the time of PCI when they had multi-vessel disease. They were randomized to a complete revascularization, and this wasn't at the time of PCI because patients were randomized after the culprit vessel was intervened, but it was at complete revascularization within 30 days after their STEMI, or either a staged or in the hospital, versus the culprit lesion only PCI and then watching for symptoms. The patients who had complete revascularization had a reduction of cardiovascular death and MI. That was a very, very important co-primary endpoint of this study, cardiovascular death and new MI. And of course, the other primary endpoint was the cardiovascular death, MI, and revascularization, which was also positive. But I pay attention to this very, very important endpoint, hard endpoint of cardiovascular death and MI. There was a major reduction, a 26% reduction in new MI and cardiovascular death over a 4-year period, which was durable. And as you can see, look at those curves in the small, in the blown up session. You see the curves are separating over time. In fact, the benefit is coming a little bit further, that such that complete revascularization patients It separate right away within the first year, but take a look, it's actually separating even more. And we also looked, and this was presented at TCT, that the timing of the complete revascularization didn't matter, whether it was in the hospital or outside of the hospital, as long as it got done in the first 30 days, 30 to 45 days after the STEMI, there was a very, very big benefit for these patients. So it was okay to send the patients out, but it needed to come in, and these patients did need to come back and get their revascularization within 30 days in a staged manner. And you can see that this was, I believe, is a changing of our guidelines based on this trial. But it is important that this is not the same in every single scenario. Now, in the past, the shock trial did show, by Judith Hochman a long time ago, did show that you should do revascularization. Well, Holger Thiel and his team actually randomized over or close to 700 shock patients. These are really difficult studies to do. And what they did is they said complete revascularization, multivessel PCI in cardiogenic shock versus just taking care of the culprit and getting out of the cath lab. In this study, it was completely different. The patients who had multivessel PCI at shock actually had a higher rate of their 30-day risk of cardiovascular, of death, all-cause mortality, and severe renal failure. That was the co-primary endpoint, and it was worse for multivessel PCI. So in shock, it's a different story. And I think we really need to sort this out. When you have hemodynamic compromise and cardiogenic shock, it seems that it's best to just take care of the culprit vessel and then go on if you want to, especially on the renal failure and death episodes. What about the pre-hospital antiplatelet therapy and STEMI? This is a very big subject of situation that I think we're going back and forth. The ESC guidelines in 2018 actually recommended, of course, aspirin, and they're saying a loading dose of a high dose, which we also agree with. In our guidelines, we say chewable aspirin immediately. There has to be given initial loading dose, no matter what they were on. They need to get a chewable aspirin, 325 milligrams. But then they also say a potent P2Y12 inhibitor is recommended before PCI and maintained over 12 months unless there's a risk of bleeding. This is interesting because it's in contrast to some of the reloading studies, but they believe that this is incredibly important. For non-STEMI, the management is very, very different. It depends on the risk of the patient. The very high-risk patient gets an immediate invasive approach, less than 2 hours. The high risk gets less than 24 hours, and the intermediate risk, that which would be a patient with diabetes, chronic kidney disease, post-infarct angina, race risk score more than 109 but less than 140, recurrent symptoms on non-invasive testing, they get about greater than 72 hours. And this is really, really important because I just presented the data to you. I love how the Europeans do this level of really looking at the risk and not one size fits all for all non-STEMI. And this is really, really important. What about CABG versus PCI in non-STEMI patients? There's very little data here, but this particular trial is data pooled from 3 randomized studies: Syntax, Combat, BEST, 1,246 patients presenting with a non-STEMI. They had multivessel disease. And you can see here that the difference of MACE, there is a difference of MACE. And you can see that CABG it does better than PCI in this is a reduction of the rate of the myocardial infarction. And I always say the devil is in the details because this was a primary outcome of death, MI, and stroke. The reduction was all from less MIs, but remember in these studies, CABG didn't really look at MIs, peri-procedural MIs were different. And so it's very, very important to note that I believe that it all depends on the patient and on the center and what kind of lesions and date and syntax score you're dealing with, and what are you seeing in front of you to make a decision, an informed decision about PCI versus CABG in patients with multivessel disease to get them a complete revascularization. And you can see here that this is the multivessel disease, and you can see right here that the benefit is all in the high syntax score patients, and even maybe in some of the left main patients that present with a non-STEMI. Let me go back again to the PPCI antiplatelet regimen. They are giving this recommendation of the potent agent prasugrel in P2Y12 naive patients, or ticagrelor, whether or not you're on a P2Y12 regimen. And then, of course, clopidogrel is given if you don't have those two agents available, to give the double dose clopidogrel 600 milligrams only if you are not available or contraindication prasugrel and ticagrelor. What about the intraprocedural anticoagulation, bivalve versus heparin? Well, I think, as you know, I spent a whole decade of my life working on bivalirudin studies. We showed a reduction in bleeding, but it was always against the DP2P3A inhibitors. There was no question that if you give bivalve, you can reduce bleeding, but most of it is secondary to the fact that the comparator had DP2B3A inhibitors. But the risk of bivalirudin, if you're not having it, no P2Y12 on board, good potent P2Y12 inhibition on board, which is what we had, there was an increase in rates of stent thrombosis, and that's the trade-off. And I think it's important that now I think bivalirudin is a judicious use when heparin is not available, or there's HIT, or you're dealing with a patient who's at a very high bleeding risk and you want a consistent and a short-acting drug, but otherwise heparin is what is there. So just to go back on the P2Y12 inhibition and what we're doing, and this is basically from the guidelines, the DAP guidelines that we did, class 1 recommendation for 12 months of an acute coronary syndrome, no matter what the patient ends up having. So whether you do CABG, PCI, medical therapy, lytic therapy, whatever you do, this patient will require 12 months of dual antiplatelet therapy. But now this is going to be revisited after we just presented the Twilight study. But the maintenance, as you can see here, for the guidelines in patients with an acute coronary syndrome, as much as you can, is 12 months, unless you have a high bleeding risk. And here, they use the precise gap to evaluate those patients. In those patients who have a high bleeding risk, you can go down to a lower level up to 6 months and even up to 3 months when your bleeding risk is very, very high. And I think that's an important piece, and you could de-escalate as well. The update in DAPT in 2017, the new recommendations for the European Society, and the change in recommendations are there, is really actionable bleeding is very, very important to reconsider the DAPT regimen. It's important to think about bleeding much, much more. There is a liberal usage of PPI to mitigate GI bleeding. Decision of the duration is dynamic for DAPT. You have to take a look at the patient at different times. You can discontinue when you have a high bleeding risk, as I discussed. The ticagrelor interruption before surgery is about 3 days, as opposed to where it was 5 days. Elective surgery, that requires discontinuation after a month, is now getting a little bit of a 2B recommendation, if you can say, or a 2A recommendation as you need it. I think it's important to take a look at these and understand them. The revised concept is that we now are going completely to a drug-eluting stent. Bare metal stents are out in patients who are at high bleeding risk, even with an acute coronary syndrome, especially with an acute coronary syndrome. You can use risk scores to evaluate the risk of the bleeding, and you have to understand in complex PCI what that is and what are you doing with anticoagulation and DAP and the dosing regimen. And at the end of the day, it's all about the balance, as you know. Currently, there are several risk scores. There's GAP and the precise GAP score that has been mentioned in the guidelines. But I want to also give you the parents' risk score, which we
Sorry,
developed.
Dr. Mehran, sorry, you very close to to your time ending.
Okay, I just want to finish to let you know that, let me just tell you that I thought I had 45 minutes, so I'm sorry. But let me just tell you where we are. Let me just give you this one piece on Twilight, if I may. Is that okay, Professor?
Yeah, I think if you could
Okay.
conclude in half a minute.
Absolutely.
And I have a request for Dr. Wilson. The technical staff tells me you have to rejoin again. There's a technical hitch so that you are ready online by the time Dr. Mehran ends. Please. Can I request Professor Sohail Aziz, who's so diligently put together such a fantastic meeting, to say something in the meantime?
There's a lot of data, sir, to suggest that, in coronary heart disease, we need to separate the acute syndrome with the stable coronary artery, and which has now been defined as chronic coronary artery disease, chronic coronary syndrome. The data which is raising so much controversy is the stable angina. We was reading about the ischemia trial now, and we read about the courage trial earlier. But there's no doubt that whenever we deal with these, you divide these the whole spectrum into two: acute syndrome and a stable syndrome. And the data is very overwhelming that in acute syndrome, it is the early response which is very beneficial, and that's what we saw in this data, that earlier the better. But once you get the balloon time below a certain limit, there's no further benefit in reducing the door time less than 50 minutes or whatever. That is the reason they say the next thing which will help reduce the mortality in acute MI is to get the defibrillator to the patient as quickly as possible. That's why they suggest that you should not drive to the emergency. You should call in 911 emergency response so that the defibrillator comes to you earlier, and that you do not have to go through a check post or whatever. They drive you straight into the cath lab. So that is one thing. And similarly, in non-ST ablation MI, the earlier this intervention is done, the better it is. About the antiplatelets, we've got these wonderful new antiplatelets going on, but bulk of the data is, we've got all the things right. So it's the time which is of essence into.
Thank you, Dr. Sohail Aziz. We've got Dr. Ruxana back on the line. Dr. Ruxana, can you conclude in 30 seconds? We don't have her sound. Dr. Mehran, we've lost your sound. I think time is running out. We would like to thank you for your excellent talk, and would like to now welcome Dr. Wilson to his talk on management of late presenter STEMI cases.